Hello and welcome to our webinar. We have with us today Professor Rob Newton. He is going to speak to us about exercise medicine for people with breast cancer. Before I formally introduce Professor Rob, I want to acknowledge the lands that we are on today. I'm streaming here from Whadjuk Noongar country, and I'd like to acknowledge the elders of the past, of the future, and of the present era, and honour their relationship with this incredible land that we are all sharing. I invite you also to notice how you are, where you are, feel your feet on the earth, maybe take a couple of breaths and settle in as we get updated on the incredible breakthroughs and advances in the science of exercise medicine. Professor Rob Newton is a really great friend of all of us here. He's a professor of exercise medicine at Edith Cowan University, where he leads the Exercise Medicine Research Institute, which he also established in 2004. Professor Newton is an accredited exercise physiologist, a certified strength and conditioning specialist with distinction, and a fellow of the American College of Sports Medicine, Exercise and Sports Science Australia, and National Strength and Conditioning Association. Rob and his team have been doing world-leading research. They've resulted in multiple awards for their work and a great deal of impact, including for our clients here at Breast Cancer Care WA. So without any further ado, I'm going to hand you over to Rob. You're muted, Rob.
Oh, sorry, it's the first time I've done this, so I'm a little bit lost. Thanks, Chandrika. Sorry, I keep doing that. Look, it's great to be here, and it's always been a fantastic opportunity to work with Chandrika and Breast Cancer Care WA. But also, I think I'm just very humbled to be able to speak on this topic, very, very important topic, application of exercise medicine to support people with breast cancer. And to all of you today, I really appreciate you coming online, and also at the end we will leave some time for questions as well. So I'll start my presentation. It is coming. There we go. Okay, so I hope that you can see my presentation. Okay. First slide. Yep, great, thank you. Okay, exercise medicine in breast cancer management. So let's just have a couple of little definitions, because it's very important just to get the lay of the land and some of the little differences between exercise versus physical activity. So physical activity is basically any activity that you do where you are producing bodily movement by your skeletal muscles that requires energy expenditure. So this is very, very broad, and physical activity is exceptionally important for all humans. But I hope by the end of this presentation you'll realise how important physical activity and exercise is, particularly when you're going through a cancer journey. But the World Health Organization is quite specific that physical activity should not be used interchangeably with the term exercise, because exercise is a subcategory of physical activity. It's planned, structured, repetitive, and purposeful, in the sense that the improvement or maintenance of one or more components of physical fitness, this could be the capacity or structure or function of the body, is the objective. And also, of course, tied into this is the maintenance or improvement of health as well. Exercise medicine is a term which is being increasingly used, and it's the physical assessment and prescription of exercise, but specifically for the prevention or treatment of injury or illness. Now, exercise oncology is specific to cancer management, and this is a relatively new term, probably has only arisen over maybe the last 3 to 4 years, but it's being increasingly used for this particular discipline. Now, you might think exercise, how can that be a medicine? Well, it's because when we exercise, we create enormous chemical changes within our body, and also a huge drivers for structural changes as well. When we exercise, it drives endogenous medicine. So this means endogenous, which is produced from within, rather than exogenous, is from without. So this would be, for example, if you were to take a tablet or receive an injection or chemotherapy infusion. Now, this internal medicine includes a whole range of hormones and cytokines. And so these are very powerful signaling molecules within the body that really drive all aspects of our bodily functions. But also, exercise has a huge impact on our immune system. And we'll see in subsequent slides how exercise greatly enhances, it turbocharges our immune system. And this is probably one of the critical ways in which exercise can be used as a medicine to improve outcomes for people with cancer. Now, exercise also drives direct structural adaptation and repair. For example, exercise is the most effective way to maintain or improve your muscle and in particular your bone health as well. Exercise also alters blood perfusion and enormous vascular adaptations, and we'll see why this is so important, in particular for solid tumours such as breast cancer. We now know that exercise facilitates other therapies. It actually enhances the effectiveness of chemotherapy, radiation therapy as well. And in particular, it ameliorates, it reduces the side effects of these treatments. If nothing else, if none of those exercise medicine results actually occurred, then exercise would still be crucial for people with breast cancer simply because it improves your physical and mental resilience. I'll just give a couple of quick definitions here so we can move on through the subsequent slides so you'll know that what I'm actually describing. The two main modes of exercise are aerobic exercise, which is the exercise involving large muscle groups activated repeatedly over an extended period. So most of you will be familiar with this form of exercise. So it's walking, jogging, running, cycling, rowing, etc. Now there's two types of aerobic exercise: moderate intensity continuous training. So this is where you go out and you walk briskly for 30 minutes at a relatively constant speed. But also increasingly, we're using high intensity interval training. And this is where you intersperse periods of quite vigorous exercise and then recovery periods of lower intensity exercise. So practically, if you thought of this, it may be that you are on the out in the park, you're outside enjoying the sunshine, and you do a hard effort for maybe 1 minute where you're walking or even jogging, and you would describe the intensity of that exercise as about 8 or 9 on a 1 to 10 scale. So you exercise intensely for a minute, and then you walk just at a slow pace for 1 minute to recover, and then you repeat. So that is high intensity interval training. An important point here that is well established through a large number of research studies is that for aerobic exercise to be effective as a medicine for people with cancer, it must be moderate to vigorous to be of benefit. Doing very low intensity exercise doesn't create the internal medicine and structural changes that we need to improve cancer outcomes. The other main mode of exercise is termed resistance training. Now, this involves performing repetitions against some form of resistance. For example, you can see against the leg press here where the participant is lifting this weight here. But the resistance must be such that you can only perform between 8 and 15 repetitions of the exercise before fatigue sets in and you can't lift that weight any further. Now, in the clinical setting, it's fine to stop what we call a set of exercise 1 to 2 repetitions before neuromuscular failure. So neuromuscular failure is when you can no longer actually complete the repetition because your muscles are fatigued to a level where you have to recover for a minute or so before you can do another set. So that's important. The intensity needs to be around 8 to 15, what we call repetition maximum there. If you can lift the weight 50 times, it's not really resistance training. It needs to be heavy enough such that you can only perform around 8 to 15 repetitions. And this is important for a whole range of physiological reasons in terms of cancer management. Now, a lot of you are in this webinar because you're interested in exercise, and this focus on exercise for people with cancer was not really evident 20 to 30 years ago. In fact, 20 to 30 years ago, the clinical recommendation for patients with breast cancer was that they should rest. Clinicians would say, look, you have cancer, you're going to go through these treatments. You really need to just rest. Try not to don't exert yourself too much. Try not to, in particular, do vigorous exercise or lift anything which is too heavy. Well, move forward 20 years and that's changed entirely. And the rest strategy has been totally rejected. And in fact, it's a huge amount of evidence now demonstrating that those patients that remain sedentary have much worse outcomes. Now, one of the early studies back in 2005 was in a very large number of patients with breast cancer. And what they looked at was how much exercise per week these patients did, and then their relative risk of death specifically from their breast cancer. So they normalized it or benchmarked it, I guess, against less than 1 hour of physical activity per week. And that's here as one. But people that did 1 to 3 hours of activity had about a 20% reduction in risk of death. And those that did 3 to 5 hours had a 50% reduction. So this is a very, very large improvement in mortality from breast cancer. So this is one of the early studies where clinicians and researchers went, wow, people who are more physically active, they're actually surviving better. And this was quite astounding. And this started very much to challenge the idea that people with breast cancer should actually rest. This is a subsequent study published much more recently, 2016, and this was looking at studies post-diagnosis and cancer-specific mortality. And you see that at the time, most of the studies were in breast cancer, some in colorectal and then prostate cancer. Now, this is what's called a forest plot. And what it shows is the relative risk of cancer-specific mortality. And so 1.0 means no difference. There's no difference between those patients that are physically active versus those that are sedentary. So there's no benefit, but there's also no harm either, we see there. If it was 1. However, if we look at the studies here, we see in breast cancer, pretty much all of the studies, the relative risk is actually less in those patients that are physically active. And there was only one study here which showed no benefit. And that's pretty consistent across the other cancers as well. And overall, if we look across all of these studies, we see the relative risk was about 0.63. In other words, the risk of cancer-specific mortality was reduced by about 37%. What's also important here from this quite large study in literally thousands of patients with cancer is that none of the studies showed a relative risk greater than 1. In other words, no study showed that being physically active actually increased your cancer-specific mortality. Now that's important because 15 to 20 years ago, many clinicians were of the opinion that physical activity and exercise would actually exacerbate the cancer, or that it would compromise the therapy intent, and it would actually make the outcomes worse. So 2016, there was no evidence of that, and subsequently to that, we're almost 8 years later, there is still not a single study which has been reported indicating that being physically active post-cancer diagnosis causes any harm in terms of cancer-specific mortality or overall mortality. So across these 26 studies, as I said, about a 37% reduction of risk. So a lot of people ask, well, is that any good? Is that important? Is that clinically meaningful? So this was an editorial in the Journal of Clinical Oncology, which is one of the leading cancer journals in the world. And this is what the editor wrote. The data from these studies suggests a reduced risk of recurrence or death. In some studies, it's around 50 to 60% reduction. And the editor actually wrote, such an effect parallels that of Herceptin for HER2-positive breast cancer patients. An agent heralded by the oncological care community, the director of the National Cancer Institute, as a major advance and turning point in eliminating suffering and death from cancer. So here we have a drug therapy for which being physically active produces a similar reduction in risk of recurrence or death. However, very important, exercise is not an alternative to chemotherapy or radiation therapy or targeted therapy. Exercise is a critical synergistic medicine in the management of cancer. Exercise will never cure cancer, but it is an important adjunct treatment. So this is a very nice schematic of how exercise medicine is being applied today across the phases of the cancer journey. So if we look at here, post-cancer diagnosis, exercise is being applied as a pre-treatment. So it's applied as a treatment prior to the main treatment that the patient is receiving. So this is more about treatment preparation, getting the patient ready for their oncoming treatment of surgery or chemotherapy. So in this instance, it's said to be neoadjuvant exercise medicine. A clear example here is a patient who has been diagnosed with breast cancer and is preparing for their surgery. Now, in the main, surgery is not urgent, and there is a period there anywhere from 2 weeks, perhaps even out to 8 weeks, before the patient will actually undergo their surgery. This is an excellent opportunity to intervene with exercise medicine, to actually make the patient more resilient, to improve their immune system, perhaps to improve their body composition, get their body fat down and their muscle mass up, improve their cardiorespiratory fitness so that they tolerate the anesthesia better. Now, there is now a large amount of high quality research trials demonstrating that exercise medicine in this pre-treatment phase results in less time in hospital, fewer surgical complications, fewer infections, better outcomes from surgery. And we also see this when it's used as a pre-treatment leading up to chemotherapy as well. Now, next, we see the application of exercise as a medicine during treatment, and this is said to be adjuvant exercise medicine. So it's a treatment which is given at the same time as the main treatment. Now, this doesn't apply to surgery, of course, but it definitely applies to chemotherapy, radiation therapy, targeted therapy, and immunotherapy. And the purpose here is to improve treatment effectiveness. We now know that exercising over the course, for example, of chemotherapy actually makes the chemotherapy more effective. And we'll look in subsequent slides as to why this occurs. The other large benefit of exercising over the course of therapy is it ameliorates the side effects. Vast reduction in side effects of chemotherapy and radiation therapy in particular. The next phase, of course, is applying exercise medicine after the main treatment. And so here it's said to be used as a rehabilitative treatment. And this is all about recovery, helping the patient to recover from their surgery or phase of chemotherapy, improving their fitness and body composition and resilience. The next phase, of course, is the patient is effectively in survivorship now. Their cancer has been treated, they've finished treatment. And here at this phase, it's very much about disease prevention. And this is about, firstly, reducing the risk of recurrence. And there's very good evidence of a reduction in the risk of recurrence of the primary cancer here, but also reduction of the risk of the development of other chronic conditions. For many patients going through cancer treatment, they are now cancer-free. However, this period of treatment here has greatly increased their risk of other chronic diseases such as cardiovascular disease, metabolic syndrome, type 2 diabetes. Exercise again here greatly reduces the risk of all those other chronic diseases. Now, in the next phase here, if the cancer can no longer be treated and the patient now is in a period here of palliative management here, again, cancer exercise has an important role here in supporting the patient. And this is primarily because it helps to maintain quality of life during this phase, help to maintain physical function and interaction, social interaction, etc. during this phase. It also helps to reduce the fear, the anxiety, and mental health concerns that the patient has as well. Now, increasingly, we're seeing evidence that in this phase, exercise as a medicine will actually enhance survival during this period as well. So let's have a look at a few examples of published research, just a few snippets here of some mechanisms by which exercise as a medicine is so effective in the overall management of cancer and how it might actually contribute to that improvement in survival. So this is a nice study here. This is in patients that are receiving chemotherapy. And these patients either received usual care or they were involved in two different types of exercise program, one called On Track and the other one was called Onco Move. And what they examined here was the side effects that were occurring here, the toxicities, if you like, of chemotherapy, and then the actual reduction in chemotherapy dose. So, as many of you will have experienced, the chemotherapy, whilst highly effective for suppressing the cancer, does have a range of side effects. And this might include neuropathy or febrile neutropenia, nausea, vomiting, fatigue. And because of these side effects, the medical team has to actually reduce the dosage of chemotherapy that the patient's receiving. Now, in usual care, in this particular study, overall, there was a 25% reduction in dosage of chemotherapy. However, in the two groups that were exercising, there was only a 10% reduction. So the patients in these two groups were receiving much closer to the originally planned dosage of chemotherapy. And so this may in part explain why patients who are physically active, they tolerate the chemotherapy better. So there's less dose reduction. So there's greater likelihood that the chemotherapy will be effective and extend their survival. Now, this is an interesting study here. It's not a human study, the previous one was, but this is a study actually in rodents. And what they did was they took these animals, these mice, and they injected them with human breast cancer cells. And they divided them up into 4 groups. Half of the mice received chemotherapy at 7, 9, and 11 weeks. And half of the animals had a exercise wheel placed in their little cage, their house. And so this gave us 4 groups, as you can see. What they did is they then looked at the density of microvessels within the actual breast cancer tumours that grew within these animals. And what they observed was that the density was much higher. So in other words, the blood perfusion and the vessels flowing through the actual tumour within the animals was much better in the exercising animals. What they also saw when they looked at the volume of tumour, so the size of the tumours that developed, what they saw, this is the control animals that didn't receive chemotherapy or exercise. And these two groups here were the animals that received either chemotherapy or exercise. And what we see is that the growth of the tumour actually tracked together. So in this case, in this particular study, the exercise was as effective as chemotherapy for suppressing the rate of growth of the breast cancer. However, what they also observed was the group that received exercise and chemotherapy had an even slower rate of growth. Let's move to a different study. This one here is quite interesting because this was actually in prostate cancer, but it involved 10 healthy males that cycled for 60 minutes. And what they did is they extracted their blood pre and post this bout of cycling, and they extracted the serum, so the liquid portion of the blood, and then they poured it over living prostate cancer cells. What they saw is in 9 out of 10 individuals, that serum, post-exercise serum, actually suppressed the growth of the prostate cancer cells. When they pooled the exercise serum, so mixed it all together, they observed around a 31% inhibition of growth. So here's the data from that study here, and this is the acute effect of exercise. So what's happening here is that when we exercise, the body is producing substances which are dissolved in our blood that actually have anti-cancer effects. They are signaling to the cancer cells to either die or to slow their rate of growth. They're suppressing the cancer cells directly. So a very interesting and important study. Now, this is another study here. This, again, this is in rodents, in mice. And what they did was, again, they took the animals and they divided them into two groups. There was 12 animals, and they injected these animals with melanoma cells. And then they had half the animals had a exercise wheel placed in their cage. Each animal has their own cage, and half the animals, 6 of them, had an exercise wheel placed in the cage. The animals are all in the same room, same conditions, they get the same food. The animals are all genetically identical, so they're bred, so they are absolute twins. They are genetically identical. And then they sacrificed the animals after a period of time, and they looked at the volume of the tumour that developed. And you can see here the difference in the volume between the animals that had an exercise wheel versus those that didn't, and the number of tumours that developed, in this case in the lungs, because in this particular model, the melanoma cells tend to grow in the lungs here. Now, they then extracted the lungs from these animals, and you can see quite graphically here, these are the control animals that didn't have access to an exercise wheel. And you can see the black parts here are the actual melanoma tumour that has grown in them versus the exercise animals here. So a vast difference. Now, what they also observed that the lungs of the exercise animals were absolutely saturated with natural killer cells. And what they reported was that the exercise is actually mobilizing natural killer cells. So, if you like, activating the animal's own immune system. And this is being driven by adrenaline or epinephrine, and also another signaling molecule called IL-6, which is actually mobilizing these natural killer cells to invade the lungs, the tumors here, and actually control or suppress the cancer development. So this is a paper that we published in 2021, and what we proposed here was a range of mechanisms by which the various signaling of different molecules within the body actually suppresses the progression of cancer. And we propose this as helping to describe why patients who are physically active actually have better cancer-specific survival outcomes. And we see here that when we exercise, our muscles actually produce a whole range of hormones and other molecules which are called cytokines. We now know, and this has been only discovered in the last 10 years, that our skeletal muscles, so the muscles that produce movement in our body, are actually our largest endocrine organ. In other words, they are pouring out a whole range of chemical signals, hormones, and cytokines, which are signaling every other tissue in the body and every other organ system in the body, including our immune system, and including signaling directly to cancer cells. And they have direct effects on the cancer cells to decrease proliferation, increase apoptosis, or what is termed cell death as well. However, we have a yin and a yang, because also we know that the adipose tissue or the fat tissue in the body is also an endocrine organ. And our fat cells are also pouring out a whole range of signaling molecules as well, which tend to have the opposite effect. They tend to increase insulin, increase glucose metabolism, they increase inflammation and reduce our response to insulin and other hormones as well. So we have a yin and a yang effect here. And this helps us to understand why patients who have a higher fat mass and lower muscle mass have worse cancer-specific outcomes. And it's because the fat tissue, in terms of the signaling and the mechanisms that it drives, is overwhelming the more positive benefits that are driven by our skeletal muscles. Now, these signaling molecules produced cause mobilization of natural killer cells. These are a very, very effective immune cell within our body that then are driven into the tumor here and activated and are really, really active in suppressing and destroying cancer cells. So let's change tack here, quite different here, looking at the actual effects of as the tumor grows and the problem of poor vasculature within the tumor. Now, in a normal piece of tissue, so if you think of muscle tissue or liver tissue or whatever, you have this nice ordered vasculature here. So these are at the microscopic level. But within tumors, it's all in disarray and it's very disorganized. It has very poor blood flow and low levels of oxygen. Now, that is of benefit to cancer cells because they are not as compromised by low levels of blood flow and low levels of oxygen, whereas healthy cells are impacted. And also this low level of perfusion tends to drive the cancer cells to change, to adapt, to evolve, and including to actually metastasize. Because they have low levels of oxygen and blood, the cells adapt, the cancer cells, and it tends to cause them to metastasize. In other words, to spread to other parts of the body. That's now classified as stage 4 cancer, much more difficult to treat. Now, what exercise does is it actually helps the effectiveness of radiation therapy. Now, I won't go too much into this diagram, but there has the effect, the direct effect of radiation therapy on the breast cancer cells, where they cause that damage to the DNA of the cancer cell, and in instances, that cell will then die. However, there is also an effect where the radiation creates a highly toxic molecule within the cancer cell, which causes damage to the DNA as well. But if there is not sufficient oxygen, that process can be reversed. So the availability of oxygen produces what is called the oxygen enhancement effect. And so it's very important to have good levels of oxygen within the cell when radiation therapy is applied. So I'll keep moving along here because I am conscious of the time, but exercise during cancer is very, very important to help normalize blood vessel structures within solid tumors so that they have greater blood flow for a whole range of reasons. It enhances radiation therapy, but it also causes greater delivery of endogenous factors such as anti-cancer immune cells and those signaling molecules that I mentioned earlier into the tumour. We are now also recommending that patients exercise immediately prior to receiving their radiation therapy, because this increases blood flow, and again, it enhances that radiation, that oxygen enhancement effect of radiation therapy. I'll change tack now and just talk a little bit about the effects of body composition. Large amount of evidence now demonstrating that patients with a high fat mass and low muscle mass have much greater toxicities of chemotherapy. And the reason for this is that when receiving systemic therapies, it is according to body mass or surface area. It is not prescribed according to actual body composition or ratio of muscle and fat. Now, cancer drugs distribute predominantly in metabolically active tissues. So patients who have what is called sarcopenic obesity, which is higher fat levels and lower muscle levels, have much higher risk of toxicity and dose reduction. This is because the most sensitive organs like blood, bone marrow, highly perfused organs such as heart, lung, kidneys, and brain, in a patient with high fat, low muscle mass, you have much greater toxicities in these organs. Exercise causes the muscles to be perfused more, and so they take up and add to the volume in which the chemo can be distributed, and so less of the chemotherapy actually targets more sensitive tissues. This is just one example of how that plays out. Now, this is sorry for the complexity of this slide, but what it is comparing is those patients with low muscle mass here, or what is termed a skeletal muscle gauge, versus high. And what we see here is those with low skeletal muscle gauge here, less than 1.475, have much higher toxicities, more than double. Hematological, gastrointestinal, neuropathy, hospitalization even, and dose delay or reduction is much higher in those patients with low skeletal muscle index, if you like. I think I'll skip over that one. This is an interesting study here, because what it was looking at is the association between muscle and fat and survival in patients with non-metastatic breast cancer. And here what we see is those patients with sarcopenia. Sarcopenia is a condition of low muscle mass. That's a simplistic definition of it. But we see that patients who do not have sarcopenia, in blue here, versus patients that have low muscle mass, this is their survival years post their diagnosis and their evaluation of muscle mass here. And we see that survival is much worse in patients with low muscle mass. Also, we see patients with low radio density of their muscle. So in other words, this is a measure of the quality of muscle. So it's not only the mass of muscle, the amount, but it's also the quality. Those with low muscle quality, again, much worse survival. Now, patients with different levels of overweight, fatness also, or adiposity, also that is a factor. Those with the lowest level of fat have much better survival. However, the overall recommendation or overall outcome here is that sarcopenia caused a 41% greater risk of dying from their cancer, whereas the highest third of adiposity, a 35% risk. So what this tells us is, yes, look, being overweight is a problem in terms of high fat. It does compromise survival. But in all likelihood, low muscle mass creates a much greater risk of mortality from the cancer. I just want to talk briefly now about the issue of lymphedema, and a fairly concerning portion of patients with breast cancer will develop lymphedema of the upper limb, because quite often the surgery, after they have surgery and or radiation, it will damage the lymph system. So the lymph nodes, they may be surgically removed for observation to see if the cancer has actually spread to the lymph nodes. But this can compromise the return of lymph fluid and create lymphedema, which is this swelling of the affected limb. Now, back maybe, 15 years ago, patients with lymphedema were recommended not to do exercise, in particular not to lift weights, for fear that it would exacerbate the lymphedema. Now, we did a series of studies here, and this was published in 2013. And what we found that the performing upper body weight training with either heavy or light has no impact on lymphedema. So it does not exacerbate the lymphedema in these patients with breast cancer related lymphedema. We then exercised, as we see here, these patients over 3 months. So that was the acute effects, the previous paper. And what we saw that regular exercise over 3 months did not alter the level of lymphedema. However, we observed nice improvements in strength and physical function. And there were similar effects observed for both heavier or light weights, although we see perhaps a slightly greater improvement for heavier weights. It was only a 3-month study. I would suspect that if we carry this over a longer period, the heavier weights would have been more effective. Now, I think I'll just skip over this one. So I just want to move to the current Australian guidelines for exercise medicine in cancer management, with my colleagues and I published in 2019. And what we proposed is a much more targeted approach to exercise prescription for people with cancer, assessing the patient, determining, prioritising the health issues, working out what is going to cause the greatest morbidity or mortality risk for the patient, and then creating a tailored exercise prescription for the patient. Now, the foundation guidelines is that most patients would receive a multimodal program, so a combination of aerobic and resistance exercise, but there may be different emphasis on either of those according to priority. It needs to be of moderate to high intensity. Frequency should be most days of the week. Spread the dosage. If possible, it is better to receive your exercise medicine on 6 days per week. Give you 1 day of rest, if you like, rather than try and do all of the exercise dose on just 2 or 3 days. If you had a headache, you wouldn't take a whole bottle of Panadol in the morning. You would take a few tablets spread across the days. To accumulate the exercise medicine over the weeks and months. Progression's important. Periodization means varying the exercise across the week, month, and even around events such as chemotherapy infusions. And also auto-regulation. What this means is that when the athlete, this was originally used with athletes, it still is. And this is where we derive this idea from, is applying it now to patients. So when the patient comes in for their exercise program and we ask them a few questions, how well did you sleep? How is your pain level? How vigorous or vibrant do you feel? Or how fatigued and flat do you feel? Has anything changed in your symptoms, or has your health professional told you of anything new? Now, based on that, we will adjust or auto-regulate the exercise program for that particular session. If they come in and they're jumping out of their skin, then if we had a fairly modest, continuous exercise program like pedaling on a cycle, then we might change it. Said, no, let's utilize this, and we'll get you doing some high-intensity interval training or some really targeted resistance training. If, however, they come in and they say, oh, geez, Rob, look, I feel really flat. I had chemo a couple of days ago. I just feel dreadful. Then if we had a fairly intense session plan, we'd alter that and say, okay, well, let's just put you on the bike. We'll go for a little bit of a pedal for 5 to 10 minutes. And then, perhaps go home and do some recovery activities. Or we might just say, well, let's just do a nice stretching session with some mindfulness or meditation. So auto-regulation. Excuse me. Also, we need to address acute or chronic concerns which might require specific exercise prescription. For example, cachexia. If the patient is losing body weight rapidly, then we really need to focus on resistance training. And aerobic exercise is actually contraindicated. We don't want them going out and doing long walks because it's only going to make the cachexia worse. And we also need nutritional support. For bone loss, we need resistance training and also impact loading. So this is ground-based loading where we're trying to generate impacts up through the skeleton to try and slow or reverse the bone loss. And again, nutritional support with calcium and perhaps vitamin D supplementation. The presence of other chronic diseases. This may be a concern that the issue of cardiovascular disease and heart attack and stroke risk may actually be greater than the issue and risk associated with the primary cancer. So in this case, we really have to get the cardiovascular disease under control. So reducing body fat, increasing their cardiorespiratory efficiency, looking at their blood lipids and glucose profile, some nutrition around an anti-inflammatory diet, and then ameliorating the treatment side effects as well that might go with that. So specific exercise prescription, and this is, again, this is a more generic or global prescription, and we really are working to have actually more targeted programs. But overall, it should be in relative well patients, about 70 to 150 minutes per week of moderate to vigorous aerobic exercise, and 2 or more resistance training sessions per week, targeting all the major muscle groups. So that's the generic recommendation, but for most patients, we'd like to do much, much better than that and have a tailored prescription for them. So if they've got specific health issues, such as impaired cardiorespiratory capacity or aerobic fitness, then they need aerobic exercise, including HIIT, high-intensity interval training, targeted exercise for low bone density or high fat mass, or lymphedema, targeted resistance training of the upper limb. Other issues around arthralgia, fatigue, and even the cognitive impairment or chemo brain that can sometimes appear in some patients as well. So how do we actually go about this? Well, we highly recommend that patients seek a consultation with an accredited exercise physiologist. AEPs are the most appropriate allied health professionals for assessment, prescription and monitoring of exercise medicine for all chronic disease management, including cancer. Now, if that referral is through your general practitioner, then Medicare will fund part or all of the AEP consults. Now, this is a shameless plug for the university, but at ECU, we have the Exercise Medicine Research Institute. We do provide clinical services here. Our Vario clinic provides face-to-face and also telehealth AEP consults. That's our website there, where you can go and get more information and contact us if you would like an appointment. Now, there is also a way in which to find an accredited exercise physiologist close to you. There's the website there. It's through Exercise and Sports Science Australia. You can search at a particular location and then an area of special interest. So you could actually enter in there for breast cancer. So thanks very much. I didn't time it very well and I had to skip over a few slides, but there is our website if you'd like some more information. I want to acknowledge our fantastic team at the Exercise Medicine Research Institute and also our key funders here, in particular the Cancer Council of Western Australia and the National Health and Medical Research Council. So thank you very much, and I believe we have time for questions.
Thank you so much, Rob. That is always so inspiring and motivating and makes me feel grateful that we are offering so many ways to exercise through Breast Cancer Care WA, including
Yes.
members of your team. So we're really grateful that we have accredited exercise physiologists offering a Monday morning and a Tuesday morning session this term. I've just been checking in actually with our team and I suspect that there's an error. One of them, the Monday should be 8 a.m. and the Tuesday 7 a.m. and I think we've published both at 7. So we'll send out an update to everyone on our mailing list. But there are also some questions for you, Rob. So I'll start with the ones in the Q&A box. Someone has asked, Chantel has asked, what is the best type of exercise for medically induced menopause?
Oh, wow. Again, it needs a tailored approach. We need to assess the individual and determine what are the key issues, whether it be physical or mental health issues that are really impacting them. Again, examining body composition. If they have low muscle mass, that needs to be addressed as a priority. Again, this balance of fat mass, which is also highly involved in our hormonal function as well. If there is that imbalance in your yin, I love my yoga and my Buddhism and meditation, so I talk about yin and yang a lot. But that, we have to address that imbalance there. So it's no just global prescription that we could recommend. Certainly being physically active is highly important. Being physically active greatly reduces the side effects of medically induced menopause. It greatly reduces the problems associated with just normal aging and menopause as well. But it is about assessing that, being physically active, but also certainly exercise medicine can have a vast benefit for patients going through medically induced menopause.
Fantastic. Another hormone-related question. Do hormone blockers, like the estrogen blocking drugs, affect the release of these myokines, the muscular hormone release of healthy cells to fight cancer cells?
Wow, that is a fantastic question.
Mm.
No, not directly. The key here is that it is the amount of muscle and the quality of muscle in the body and how often it's activated. The best way to think about it is that your muscular system is a pharmacy. It's a drugstore. Okay. Uh, you can have a large drugstore like a Chemist Warehouse. I shouldn't say that. I shouldn't say any particular brands. But you can have a large drugstore like that. It has a whole range and a huge capacity to hand out drugs, or you can have a tiny little corner store like you see at the airports, for example. It's very important to try and maintain the size of your drugstore. So in other words, the size, the quality and amount of your skeletal muscle, so it is better able to pour out those drugs. So the reason why I mention that is, in the main, estrogen therapies to reduce estrogen does not cause a large amount of muscle loss. However, the psychological effects of estrogen suppression can cause reductions in physical activity, and that can then drive reduction in muscle mass. So that is the mechanism by which estrogen reduction therapy can cause suppression of the release of these anti-cancer molecules within the body.
Very interesting. The first question actually that came through was related to that slide that had the forest plot. And Annalise asked, with regards to the studies presented that show the reduction in mortality, when did the exercise commence for those patients? During active treatment or after?
Now, that's a very, very good question. In all of those studies presented, they are epidemiological studies. They're observational studies. So what they did was, at diagnosis, they asked the patient, what level of physical activity do you do? And then they worked out the amount of physical activity at that point in time. They then tracked the patient and determined when they succumbed to their breast cancer or whatever cancer. Okay, so it is more an association. It's not the highest quality of evidence. We need randomized control trials, and there are randomized control trials to actually look at survival. Having said that, there has been some nice work published where they looked at people that with breast cancer that underwent a randomized control trial as part of a study looking at other outcomes. And then they looked at how long they survived as well, which is a higher level of evidence. Again, very strong association between being physically active during that intervention and how long the patient survived.
Mhm. You may have sort of answered this one, I think, in the lymphedema section, but Donna asked about building strength when you have breast/arm lymphedema, what kinds of exercises to do and what to avoid. She said that she had an exacerbation of her lymphedema with boxing.
Okay. Um, I probably should have put a caveat there. Uh, if a person is predisposed to an exacerbation, that can be driven by anything. It could be, lifting the groceries, or it could be going for a swim. It could be lifting weights or anything. That is quite rare. The exacerbations generally occur for reasons not related to any particular physical activity or anything. But I have to put a caution on that there will be instances where you may get an exacerbation. The key point is there, well, don't do that exercise anymore until the exacerbation is controlled. Okay. The type of exercise, it's a risk benefit, because if the patient doesn't exercise the arm, then the muscle will get smaller. You'll get fibrosis and changes in the quality of the muscle, which is very difficult to reverse, resulting in lack of functional capacity and disability. I had a patient that came to me and worked with, and she had a sleeve on and she held her arm by her side. She came to me because I am a practicing clinical exercise physiologist. And we talked and said, oh, yes, I've breast cancer, I had these treatments, etc., surgery. And I have lymphedema on, I have my sleeve that I wear. And I said, oh, okay, so, what sort of function? Can you raise your arm at all? And she said, oh, yeah, no, I can raise my arm. It's not a problem. But she had been told to avoid moving her arm and avoid physical activity. And when we took the sleeve off and we did some analysis on it, she had terrible muscle wasting, and we had to spend a lot of time getting that function back. So what the message, I guess, is try exercise, start at a very low level. So lifting weights, but doing very low volume. It is more likely that a high volume, so a high number of sets and reps, like a light weight lifted many times, or boxing, where you're doing many repetition, is more likely to cause an exacerbation compared to doing, say, a single set of 6 to 8 arm curls and shoulder press or something like that.
Mhm. Okay. Another question, this might be our last one, I think, although I'll just check. This one is more general about the difficulty in losing weight, particularly around
Mm-hmm.
the abdomen, and
Mm-hmm.
whether this is something where calorie deficit is required or whether exercise alone is where the focus should be.
Wow, you people have such great questions. Are we recording this?
We are.
Okay, wow. That is, there's so many aspects to that. Okay, the visceral fat is the problem. So you've hit the nail on the head. That fat around the middle is the most risky in terms of causing cardiovascular disease and metabolic syndromes. So interestingly, exercise is most effective at reducing visceral fat. It's not very effective at reducing fat in other parts of the body. So it's what's called subcutaneous fat, so the fat that sits underneath your skin. So that's the first point. Exercise is critical to reduce visceral fat, so fat around the middle. Second point, BMI is not being used now. We are moving away from the use of BMI because it misleads the diagnosis and prescription. Waist circumference is a much better measure, and waist circumference to height is a great measure as well, because that actually assesses the fat around your middle, which is indicative of the deeper fat around your organs, which is particularly risky. Now, weight loss, fat loss is very difficult without calorie restriction. So you have to reduce the amount of food, particularly the amount of energy that's taken in your diet. Now, you have to exercise when you are on dietary restriction. That is absolutely critical. The reason why is any weight loss program, whether it be through caloric restriction, through drugs such as Ozempic or Wegovy or tirzepatide, the new GLP, GLP-1, GLP-2 inhibitors, you would have seen them all in the media, highly effective for weight loss. Bariatric surgery, all of those treatments reduce body fat, but they are also a muscle loss program. If you use those therapies alone, around a third of the weight that is lost will actually be lean muscle mass. That is a problem, particularly for people with cancer, because as I showed in my slides, mortality risk is much greater in people with low muscle mass. So you need to avoid losing muscle mass. If you diet alone or you take the drugs, your Ozempic, without including resistance training will block the loss of muscle mass. So I hope that's helpful. So you need to do a combination of dietary restriction and exercise, and in particular, that exercise needs to include resistance training.
Okay. Well, there were a couple of other comments and questions about kind of lower level exercise. I think you did answer really that it needs to be quite vigorous, doesn't it? Moderate to vigorous most days of the week.
Yes, and it's all relative. If you are absolutely smashed from your chemotherapy, then your absolute level of exercise might be quite low. So it might be walking to the front of your house and checking the mail and back. That absolute level might be quite low, but the relative level might still be moderate to vigorous, because you would rate that as, ooh, on a scale of 1 to 10, oh, that's about a 6 to 8 walking to the mailbox. That's fine. It's a relative level of intensity. Look, low level exercise, low intensity, such as walking the Labrador, or trying to think of something else.
Lawn
Um,
bowls? Lawn bowls
lawn
is one of the
bowls, lawn
questions.
bowls, lawn bowls, fantastic for your cancer experience in terms of your mental health. Absolutely. And you can't separate out the mind from the body. The maintenance of mental health is equally as important as the maintenance of your physical structure and function. However, to actually induce these internal medicines, anti-cancer medicines within the body, in order to prevent muscle and bone loss, and in order to drive fat loss, it has to be moderate to vigorous exercise.
Thank you so much, Rob. I feel really inspired, and I hope everyone listening does as well. And if you haven't yet signed up to join one of the exercise programs, either through Breast Cancer Care WA or through the Exercise Medicine Research Institute directly, or in your community, wherever you are, whatever's accessible to you, I hope that this inspires you and motivates you to keep going with all the good things and do more if more is possible for you. Rob, we really appreciate your time and your incredible level of knowledge and experience in this space. And for those who've asked, yes, this has been recorded. We'll do just a little edit of the start and finish and put it up on the website. So it will be a resource that you can listen to time and again, and you can also share with other people. And yeah, that's it for today. We have a few more webinars coming up in this series, two with an accredited practicing dietitian. So we can go into a little more of that anti-inflammatory diet and other questions that I'm sure people have. And also we have one on sleep with Professor Josh Wiley, and we also have a returning to work webinar coming up. So everyone, please stay in touch, and thank you once again, Rob.